There is currently a problem with regards to what is happening in terms of population health. It seems that the powers that be don't want to know what's going on. And the reason I'm saying this is because they're not doing autopsies. Autopsies are the gold standard. We've just had a pandemic with a novel virus. They've just injected the vast majority of the populations with a novel therapeutic. And nobody is interested in why there are unusual presentations of disease. And so there is no evidence of is being used because autopsies are not being done. So I have been waiting for now almost 2.5, coming out to 3 years for these autopsies. The first full autopsy was done in January of 2023 or published. Since then, there have been only a few scraps. Nobody wants to do them, it seems. So the options are that I have to then search for biopsies, histology, looking at cases to try and understand what is happening because there is no coordinated study going on. You have to remember as well that in Australia, one of the most valuable data sets with regards to vaccinated, unvaccinated cohorts was just about to be destroyed. 100,000 data points, and they've decided it's no longer of value. Something is not right. And so, what I'm doing here is I'm working outside the box. And so, you'll have to understand when I use these case reports, like for instance, this case here, to try and emphasize what I think is going on in terms of disease. And I'm able to extrapolate it because I understand the autoimmune responses that can be occurring across the population in relation to COVID. So I'm going to take you through this case report and I'm going to show you why, even though the authors didn't make the link with COVID, why I think that this case is an example of a COVID storm. And it's the prediction that I've had for over a year now. And again, without autopsies, we can't know for certain. Before I start, just a quick reminder, if anybody is got joint pains, please, I've just put this together, a challenge to ease pains in just 5 days. Please, if you're interested, if you're struggling, take the step. No pills, no scans, no appointments. Let's see what we can do with just innovative science. So let's get back to the case here. Um, I'm going to go through a little bit of the case, and then I'm going to explain the science about why I've said what I've said about this case. So let's get a few things in place. So the first thing is that it's an open access case report. It was published here on the 30th of June 2025, and this was in the USA, Internal Medicine. And so what they were talking about is a case of pauci-immune crescenteric glomerulonephritis. It's a rapidly progressive form of an immune-mediated kidney disease, and it was tied with another autoimmune condition, which is ANCA-associated vasculitis. Anti-ANCA is anti-neutrophilic cytoplasmic antibody. It's just an autoimmune condition. And the critical thing that they found was medullary angiitis. That's in the kidney. I'll explain where that is in a moment. And so they were discussing the fact that he presented with quite severe kidney failure. They put him on, he was treated with pulse methylprednisolone and immunosuppressants after that in order to try and reduce the risk for him needing dialysis. So they were presenting this case because it was unusual. The whole presentation didn't make sense. Now, as I said with a case report, you usually do a case report when it's something that you found very interesting or very unusual. So the first thing you know is that the authors themselves thought to themselves, wow, this is a very strange presentation. It's not that people can't have that, it's the coordination of symptoms. Okay. So let's then go into the details. The first thing you have to know is that it's a 69-year-old patient, and he had no significant past medical history. This is important. He had no kidney disease, no heart disease, no diabetes, nothing. So he had come to the hospital because his doctor had noted an elevated serum creatinine. That's a measure with regards to the kidney function. Now, this is the bit that's important. To note, 3 weeks prior, the patient was hospitalized for 1 day with pneumonia and an acute kidney injury. This is really, really important. Okay? I want you to note first the time, and I want you to note that he was hospitalized for 1 day with pneumonia. So, the reason why the time frame is important with regards to the pneumonia is that 1 day suggests that he didn't have a severe pneumonia. Usually, patients who have quite a severe pneumonia will be in hospital for 3, 4 days getting intravenous antibiotics. So, if he was there for 1 day, it was probably because of his kidney function that they wanted to monitor. He coincidentally or may have had some symptoms of a pneumonia. And so, after they had checked him out, he was okay. They discharged him in 1 day. So, it suggests he was not particularly sick. Now, what's happening at the moment, and all I can advise you is that don't get sucked into this narrative that COVID is done. Remember, the same people who were telling you every day how many people were dying of COVID are now not at all mentioning COVID, even though it's still circulating, even though it's still causing significant disease. Why is that? It's clearly not about science, it's about something else. Don't get sucked into that narrative. COVID is still there and it is pretty serious. So, what I think happened, and this is now the extrapolation, is that 3 weeks prior, he had COVID. If I was to talk to this patient, I would bet he had a little bit of a cough. His chest x ray didn't show anything on it. So, they have presumed it was a chest infection because his inflammatory markers were up, and they put him on antibiotics. They noticed the acute kidney injury, which is not normal with a typical simple pneumonia. But if somebody had said COVID at that time, it would have made perfect sense. So when he came into hospital, he had no problems. The only thing he complained of was fatigue. This is very common, and it's the most common symptom I have noticed around COVID. It's the only thing people seem to have. Sometimes they have a mild headache, but very often it's this fatigue. So you can bet if you asked him, his fatigue had started 3 weeks before, probably even before he came to the hospital. And if you listen carefully to his history, it would have been very subtle. You literally, these days, with COVID, have to go searching for it because in highly vaccinated regions, the presentation of COVID is not typical. This is very important as well. We don't know his vaccination status, but pretty good chance, based on just percentages and age, that he probably could be. But it's an assumption. It's important also to note that the COVID storm, as I predict, can happen in anyone, whatever their vaccination status, if they have a reinfection after they have been immune primed. It's just that my prediction is that it will happen far more commonly in the vaccinated cohort. So when he was admitted, they did a lot of tests. I won't go into the details about them, but his inflammatory markers were elevated, and that's what these ones are. And critically, he had a hemoglobin of 9.4. That's a red flag because why would he have anemia if he had no significant past medical problems and he only had a chest infection 3 weeks before, and he now has anemia, elevated inflammatory markers? The whole thing sounds like COVID. And the way these days that I and analyze COVID is I say to somebody, if when you're seeing all these strange presentations, if I told you that 3 weeks before this person had a positive COVID test, would you go, okay, that makes sense? Then it's COVID. Simple as. If you've got no other explanation, that's now how I approach clinical situations. If there is no logical explanation and all that you have is a mild prodrome with ongoing symptoms, it is COVID until proven otherwise. And that would also explain the anemia, because one of the things that happens with COVID is a hemolytic anemia. It damages everything is autoimmune with COVID. And this is why it presents in such an abnormal way. I'm skipping through because what I want to show you next, and this is where the important bit comes up. He was started on pulse steroids and showed an improvement in kidney function. This is really important because it's highlighting that if you don't get this diagnosis and you don't start them on steroids, their kidney function is not going to improve. That's the most likely outcome. Then he had a mild chronic severe medullary angiitis. Angiitis usually means blood vessel inflammation, along with some arterial nephrosclerosis. This is probably old, so I would bet that maybe he had underlying hypertension that wasn't diagnosed, so he may have had some mild disease if you had looked at it before. And everything that they're focused on here is the fact that this patient improved with immune suppression. And this is why I'm highlighting that if this concept or this principle of autoimmunity is not grasped urgently, a lot of people are going to suffer harm because they have not been appropriately treated. However, doctors' hands are tied. You can't just randomly put people on immune suppression. And so, therefore, they can't do it until the research is done, which shows that this is standard or most likely to occur. It is not in anybody's interest. If they're a patient, just a random person, you should be pushing for autopsies. Ask your MP. I don't know who you need to ask, but it is not acceptable that we are flying blind 5 years after, 4 years after doing mass vaccination, and nobody has any idea what in the world is going on in terms of pathology. This is pretty serious stuff. So, what I'm going to do now is I'm going to take you through what is relevant in terms of the science for you to be able to understand the patterns of presentation. So let's presume I'm correct. They made no mention of COVID in this presentation. This is my extrapolation because he had mild chest symptoms, what they thought was a pneumonia, 3 weeks before this presentation of kidney disease. And this is what I'm observing as well, is this is how it works. Now, here is what I think is going on from the pathology. Years to come, you'll come back to this and you'll see, my goodness, how did he know this? But let's look at this. The first thing you have to know is that when it comes to COVID, it literally involves everywhere. It's because it primarily targets the blood vessels. Okay. And so everywhere, heart, look at the kidneys here in this rat model. This is compared to influenza. Influenza, primarily the lungs. There's a little bit of scattering elsewhere, but nothing else. But look at what happens if you put the spike protein in the bloodstream. Kidneys, the highest lit up, then heart, brain, intestine, all the blood vessels. This is a beast of a condition. And as I said, it can appear very mild. So let's go to the kidney. Here is what you need to understand about the kidney. So here's the kidney, and this represents one unit of the kidney, which is, or two, because it has two nephrons in here. So you have about 1 million of these, or 1.2 million in each kidney. And this is the basic unit of everything that happens in your kidney. The blood supply comes in there. It then filters the blood. So a lot of it goes through these tubules and then it's reabsorbed and then it goes down this loop of Henle, continues to be reabsorbed, the water, and then finally it goes down this distal convoluted tubule into the bladder, and you pass urine. And on this side here, I'm just showing you the difference is they have different kinds of nephrons. This one goes deep into the medulla. And this is the bit that has gotten involved in this medullary angiitis, because this has gone deep into the medulla of the kidney, and the blood vessels seem to be involved in this inflammatory process. So there was some element of involvement in the glomerulus, but the main part of the involvement was down here. And this is the question I was asking myself. Why in the world would that part of the kidney be involved? And this is where it ties into my COVID storm principle. Storm meaning spike-triggered autoimmune response mechanism, usually on reinfection after somebody has been immune primed, either from infection or vaccination. So what's unique about these blood vessels in the medulla is the fact that they have pericytes around them. So this is a normal capillary blood cell, and these endothelial cells lining it, and these are red blood cells inside, plasma, this is a normal one, but in very important organs like the heart, the kidney, the brain, they have extra protection with these pericytes. And these pericytes are exceptionally important in the medulla as well, because of the amount of work that has to be done in terms of absorbing water. What you probably don't know is that that part of the kidney is critical because it pulls water. There's a very high gradient between the blood and the tissue fluid in the kidney. And so if you didn't have that good pericyte protection, you couldn't concentrate urine and you would lose a lot of water because a lot of fluid is filtered in the kidney. And this is where, as I said, down here in the medullary region here, where this important bit of concentrating, this part here seems to be affected in the kidney primarily. High concentration of pericytes in these blood vessels. So you may ask, how does this connect with what I'm talking about with the COVID storm? Well, the bit that I had found initially, I had thought that primarily the most important part of the mechanism of autoimmunity was to do with autoantibodies, and it does. But it was highlighted by a bright person. It has some issues with other things, but he pointed out the importance of cell-mediated immunity. And this really then crunches down everything to make it make sense. So these pericytes, as I had explained, the CD8 lymphocyte, which has been immune primed to target ACE2, when there is a re-exposure, they pinpoint literally specific cells. And what I'm expecting to happen here is that these CD8 lymphocytes, these are like snipers, and they just pick off these pericytes. And once these cells are damaged, they then lead to an inflammatory process around, which then causes all of the symptoms or all of the pathology that we are seeing. And you end up with a situation where the pericytes then get damaged. This is them gone gray, targeted by an immune cell. Sometimes you can get thrombus being forming in there. But now suddenly these blood vessels can no longer easily help the concentration in the kidney. That whole area of the kidney no longer functions, and the person will go into kidney failure, literally from targeting one type of cell in the kidney. This is very, very important. And when we go back to the premise in terms of what was found, you can see, I'm just trying to find it here again, kidney biopsy. So in that there, they pointed out here the severe medullary angiitis. This inflammation in the blood vessels in the medulla of the kidney was what caused the severe kidney failure. And if he didn't have steroids or immune suppression, he probably could have gone on to long-term kidney failure needing dialysis. These are very important cases. And again, what you will hear is that, well, there is no evidence that this was COVID. I understand that. But this pattern is too common. It just keeps on happening. It's about 3 weeks to a month after what appears to be a very mild exposure. Patients then present with very unusual patterns of disease. If you are not looking for it, you're not going to find it. And that's the bit that is really, really important. We are at a transition point here. Now, without this detailed work being done, everybody's going to suffer. The clinical community will not be able to properly make diagnosis, and therefore people are going to lose trust with them. The patients are then going to be suffering because they can't have appropriate treatment, or appropriate treatment is instituted too late to prevent long-term damage. Everybody loses here. The answer is so simple. Can we start doing autopsies again, especially on the vaccinated cohort? We need to know what in the world is going on, and everybody should be calling for it. So much so that if you mention this topic and somebody says, we disagree with autopsies, they are your problem. They are not part of your solution. That's where we are now. And I don't know what to say. I've been waiting for years. I've been calling for it. I can't do it myself. It needs to be done. We need as much help as we can. But until we get that kind of work done, I will continue to pick apart these case reports to try and see if I can understand some more and find solutions in the interim. As a final point, again, for those people who want further information, we found joint pain is a really big issue for a lot of people. Please take a look in the description. You can take a click on this. If you have been struggling with this, take the challenge. Let's see if we can improve your symptoms in just 5 days. So thank you all for listening. We still have a lot of work to do, and there is no easy way out of this, but let's get the research done. Have a great evening.